Good morning, good afternoon, good evening. It's a pleasure to be here virtually with you and share some thoughts about the pharmacological considerations in optimizing care for patients with limited treatment options. This is my slide. These are my disclosures. So the outline will be actually focusing on some features of patients with limited options, then switch to major drug-drug interaction including herbals and complementary and alternative medicine, and just end with tools and strategies in order to manage these topics. So from a PK point of view, that might slightly differ from what the other speakers were discussing before. We include heavily treatment experienced patients, so those that have been exposed to several drugs and usually had intolerance or resistance to most of them. And most of them are now on key anchor drugs, including boosted darunavir and or ritrovirin, that both have significant drug-drug interaction. From an graphical point of view, most of them are older patients that have been exposed to incompletely efficacious regimens in the past. So they are older, they have multimorbidity and polypharmacy that increase the risk of interactions, or they might have acquired HIV in a congenital way, and so there are usually adherence issues. But from a PK point of view, we also have end-stage organ disorder, including renal insufficiency and liver insufficiency, on top of resistance to the mutation that actually limit the options and the drugs we can use. Severe gastrointestinal issues, including malabsorption, might also be very relevant in terms of absorption. So in certain patients, it really restricts the use of drugs, and we need to increase the dose of some of them. And also, for example, treatment for severe forms of comorbidities, including cancer, actually limits the drugs we can use for treating HIV. Just to give you an idea, this is the PRESTIGIO cohort, the Italian cohort, including patients with 4 drug resistance. And this is the report about the efficacy of switching to 2 drugs with high barrier to resistance. As you can see, before switch, at least this is the list of what they actually showed in terms of drugs used, but 60% of them were using darunavir, boosted darunavir, and 20% of them were using ritrovirin. The same cohort also published recently last year the importance of concomitant disorders in these particular group of patients. And actually, out of 148, including participants, 38 presented with new events or died in the follow-up of 2 years, suggesting that they have an increased risk of comorbidities and even death. So these actually complicates the treatment of HIV because of the drugs we need to give them for concomitant disorders. But also another set of data coming from Italian cohort, ICONA, in which HTE patients, there were 10% of those included in the whole cohort, suggested they have a significant risk, 3, 5, and 8-year probability of either failing in terms of virological failure or a new AIDS event. So still, I think from the point of view of comorbidities and the severity of their health status, we need to focus on these patients and be careful in the drugs we use for them. So switching to the drug-drug interaction site of action, I think most of us think of DDIs in the liver. There's certainly the most important ones in terms of amount and the potential of interaction, but the same interaction including cytochrome P450 enzymes, but such as transporters such as PGP, BCRP, OTP, 1B1, 1A2, and etc., can be observed both at the gut level and CNS, at the kidney level, also within cells. So we might think of DDIs in all these steps in the ADME of drugs we use. This is also taken from the Liverpool website, in which of these compounds that are most used at this time, compared to almost 700 communication, and you see that in red we have deleterious interaction, and in orange we have interaction of clinical relevance, and you see that 2 compounds, three classes, say boosted ARVs and etravirine, are those with the 5 variants, that is actually the drug we use less, are those with the highest potential for DDIs. But taking a look at the study we have, I personally like this study from Spain that have very large number of HIV people living with HIV. So almost 23,000 compared to 1 million of people that not acquired HIV. As you can see, red flag and orange flag were not that common. So red flag interaction were 3%. And you see here in red, the nervous system drugs or respiratory system drugs were those with the highest prevalence, but also including orange flag interaction, cardiovascular drugs, and musculoskeletal system are those significantly involved in these DDIs. If you then go to the detail of this drug-drug interaction, as you can see again, boosted ARVs are those with the highest potential, with corticosteroids, with CNS drugs, quetiapine and clozapine, and with drugs used as antiplatelet agents in this case, so clopidogrel and ticagrelor. And we just go through these 3 classes of major DDIs. So I want to remember you that this interaction is clinically significant in terms of the use of corticosteroids and boosting agents. This is because boosting agents might increase the AUC and the half-life up to 300 times. So even if we have data on inhaled fluticasone and other corticosteroids, we need to bear in mind that even nasal drops, or also intraarticular triamcinolone, but also cream applied to the skin might be involved in this interaction. So certainly boosted agents and corticosteroids may expose patients to Cushing syndrome and all the deleterious effects of this interaction. The other, I think, clinical important field is those of anticoagulants and antiplatelet agents, because our patients are aging, and it means that they might need these anticoagulant and antiplatelet agents. In terms of anticoagulants, we do have data on warfarin, where there might be a difference between ritonavir and cobicistat, because cobicistat is just a pure inhibitor of CYP3A4, while ritonavir has some induction properties on other isoenzymes. But we also have data on the new oral anticoagulant drugs and those that are allowed to be co-formulated even with boosted drugs are actually dabigatran, edoxaban, and betrixaban, and most of the data are with dabigatran that is not metabolized by CYP3A4, but is a PGP substrate, so the interaction might be on a transporter level. We already have reports, this come from Spain this year, in which 36 patients living with HIV were prescribed with new oral anticoagulant drugs, apixaban and dabigatran, and when with interacting ARVs, mostly boosted agents. Actually, after reviewing the guidelines for the prescription of those drugs, they saw that 30% had to be avoided, 30% were actually overdoses, and only 30% went consistent with guidelines. So there was at least a 60% of inappropriate prescription of those drugs. And more worryingly, I think that in the follow-up, 2 years follow-up, 30% presented with bleeding and 5 or 6% with thrombosis. So there are certainly high-risk patients in terms of cardiovascular risk, but I think it's really important that we be reminded that this is a clinically relevant drug interaction. We also have that interesting data on dabigatran, in which the use of dabigatran, the dose of dabigatran was modeled according to renal impairment and the use of concomitant drugs. Again, the difference here is between ritonavir and cobicistat because of the interaction potential in terms of inhibition and induction. So we have here these categories after PBPK modeling, in which we need to reduce the dose of dabigatran if you use ritonavir or cobicistat, or and according to the degree of renal impairment. And bear in mind that with severe renal impairment, dabigatran is contraindicated with boosting agents, both of them. For antiplatelet agents, it's slightly more complicated because they have different pathways. And you see here in the left, the clopidogrel metabolism is mostly CYP2C19, but also a minor CYP3A4. But I think what is important to remember is that clopidogrel, and prasugrel needs to be activated for having their effect. So if we inhibit CYP3A4 and CYP219 metabolism, we decrease their activity, while ticagrelor and cangrelor, the effect is opposite, but also that P2Y12 inhibition is irreversible for the drugs here in the left and reversible for drugs in the right. So the effect is actually the opposite way around for those drugs. So I think it's one of the fields in which we need to get more data, but certainly it's complicated to administer boosting agents with antiplatelet drugs. Moving to the third field, so CNS affecting drugs. So we have, again, from the Liverpool database, we have this large table suggesting the important drug-drug interaction in terms of boosting agents, NRTIs, boosted PIs, NRTIs, integrase inhibitors, and NRTIs. We have several classes. This is just a table for antidepressants, so certainly we need to take a look at those tables in our patients. I think one point I would like to discuss with you is this TDM registry from Milan, in which they compare the plasma concentration of several CNS affecting drugs in people living with HIV. Numbers are small as compared to controls. Here in blue, you see how many of these samples had subtherapeutic concentrations. And those here with the asterisk of the arrow are those in which there was a significant difference between people living with HIV and people without HIV, suggesting that we have a large proportion of patients with subtherapeutic doses of anti-CNS drugs, and this might lead actually to incomplete efficacy. So my advice that if we use those drugs, we need to get expert consultation and adjust dose to concomitant drugs, but also to the patient symptoms and efficacy. And bear in mind, most of the drug interaction was associated in PBPK models to a reduction in the levels of anti-CNS drugs rather than an increase of them. This is an interesting population PK model of escitalopram done by a group in Switzerland. I would like to point you to this table, suggesting that here the black dots are people living with HIV, while the white ones are controls. You see that the distribution is fairly similar, so we don't see major difference in the two groups. And in the end, they simulated the concentrations of escitalopram and patients not receiving CYP219 inhibitors and those receiving that, and according to the starting dose. So if you start with 10 milligrams, you see that almost 50% of patients will have subtherapeutic concentrations, while if you start with 20, this proportion is lower to 15%. And just take a look at CYP219 strong inhibitors. Some of them are widely used, for example, fluconazole, or also PPIs are also CYP219 moderate inhibitors. So this might affect actually the number of patients within range, but even if you see here with 20 milligrams above the range of therapeutic doses. I also wanted to mention this data on valproic acid and dolutegravir, because dolutegravir is often used in patients with limited treatment options. The discussion is in the literature, since we saw an effect and some others also found an effect, but the last paper on these suggests that the drug interaction is mostly based on protein displacement and probably is not clinically relevant. So we still don't know the relevance, but I think we should just take a look at these, but probably is mostly based on protein displacement. Just to give you something from Turin, these are other drugs with valproic acid, and as you can see, even highly protein-bound drugs with, for example, etravirine, we don't see an effect of valproic acid co-administration. Here, the orange squares. So even those drugs, for example, the runavir, ritonavir, or the COBICISTAT and etravirine, actually, we didn't see a major interaction when co-administered with these antiepileptic and mood stabilizer drug. Some of the interaction are actually at the level of absorption. We have clear guidelines on what to do when we use divalent cations. I will not go through them, just bear them in mind. I think they might be important when the use of integrase inhibitors. But I want to point out that, as I mentioned before, that certain communication are really hard to combine. Actually, cancer chemotherapies expose patients to DDIs, but also to overlapping toxicities, the lack of data for some of these drugs in people living with HIV, but also to patients that have a reduced organ reserve that might expose to toxicity and increase the variability of the drugs, and so the potential for DDIs. This is again from the Liverpool website, a large table with all agents and all ARVs, and of course we need to take a look at it before prescribing cancer chemotherapies and ARVs. The last point I wanted to touch is dose-dependent enzyme induction, because we actually did something what we didn't know for a long time, but it might be that induction is dependent on the dose of the induction drug. Some of them are listed here. I want to point out the dexamethasone that we use for several indications now might have this dose-dependent induction, but most of the data are rifampicin. We already have an interesting paper presented this year at CROI, in which increasing the dose of rifampicin to 35 milligrams per kilo actually had a reduced concentration of efavirenz and dolutegravir, although the vast majority of patients were above a safety threshold. So just moving quickly to complementary and alternative medicines. This is just a survey published in 2008, 2017, suggesting which are the reasons for taking complementary and alternative medicine. You see here general health and well-being, improving immune function, increased energy, reduce anxiety and stress, insomnia also here. So it means that some of these are actually symptoms included CNS that we might want to consider while taking care of our patients. However, there are some reports of loss of efficacy of antiretroviral drugs with some over-the-counter medication. This is a case series in which 2 patients took orlistat, 1 took sinotrol, and 4th one took gunabasic. Are all over-the-counter compounds for losing weight, and actually all of them were associated with loss of virological suppression, and some of them with reduction in drug exposure in those patients. Actually went back to normality once these drugs were removed. The HIV Liverpool Interaction website also includes some herbals, and very recently in September they include new herbal preparation because of the data we might have. Even if most of them are theoretical interaction, we need to ask our patients at every visit and then take a look at what we know about the potential interaction with herbals and our compounds. Bear in mind that most of the effect of herbals are on induction, so they might affect PXR, RXR activation, similar to rifampicin, and so decrease the exposure of a concomitant drugs. We know that we have data on some herbals with no interact induction, such as African potato, garlic, ginkgo biloba, and these are reported again in Liverpool website. So I advise to ask our patients and to tell them that even herbals might be important to report to the doctor, and then we need to take some time to take a look at these data and these tables. Also taking from the clinical cases DDI website, there's also a case of a patient taking efavirenz and ginkgo biloba, and this patient, this is a description of the case, there was a loss of viral suppression with, let's say, middle level viremia between 200 and 1,000 copies that actually went back to normality when ginkgo biloba was removed. So it's one of the herbals that is commonly used. So be advised about it and ask your patients about it. What about new drugs? The drugs that we probably will be using in this patient with intertreated options. Well, I put here long-acting cabotegravir, lutegravir. We know that their metabolism, they have a high potential to be victim of DDIs, but a low potential to be perpetrator. I also put them here for samsevir, ibalizumab, broad-spectrum monoclonal antibodies, dapivirine is a vaginal ring, islatravir, and lenacapavir. As you can see here, some of them have a potential to be victim, but a low potential to be perpetrators. However, we know that for samsevir might be an inhibitor of some transporters, including OTP1B1, OTP1B3, and BCRP. and lenacapavir is a CYP3A4 moderate inhibitor, and a PGP inhibitor, and a weak BCRP inhibitor. So might affect transporting other drugs. Just very briefly, I want to touch 2 points of other scenario of a limited treatment option. One is absorption. So bariatric surgery, for example, limited absorption of some certain drugs. So we actually have data for some drugs that they're actually limited. And this is something that we have less impact using intramuscular subcutaneous drugs that are just as skipping the gastrointestinal system. But also in countries with low recurses, we might have a significant impact of DDIs. This is an interesting survey published this year, suggested that at least 38% of patients had clinical relevant DDIs. Half of them were not recognized or incorrectly managed. I would just going through some of the tools we have in just 30 seconds. The first thing is just recognize and ask patients to bring their medication or use telemedicine to assess them. HIV drug interaction has this fantastic interaction checker that is very useful, and bear in mind that they have both prescribing resources, so taking a look at certain drugs, but some others look for alternatives that might help in selecting other compounds for communication. We might also have some studies suggesting how to estimate the potential for DDIs. This is an example. I think it's important to bear in mind the impact. How much is this DDI, even if we don't have data? And also bear in mind that we need not to overtreat, not to undertreat our patients. So which drugs are really essential for treating communication? That is something complicated, but I think it's important. So in conclusion, people living with HIV with limited treatment option have a high burden of comorbidities and receive several complications. And boosted agent and environment are the drugs with the highest potential for DDIs. Among those clinical relevant DDIs, I would like to remind you, boosted agent and corticosteroids, inducing inhibitors with anticoagulant and antiplatelet agents, and CNS affecting drugs, but they're often underdosed in this case. Also ask for over-the-counter medication herbals, and drug reconciliation is something we need to aim at every patient visit. And with this, I want to thank you for your attention.